tilt test useful in vasovagal, and stress testing and pharmacological testing to look for chronotropic incompetence. Adenosine test is not usually done. And the most important one amongst this entire one apart from ECG would be an external and internal loop recorder. An EP study has got a limited value. These are the diagnostic modalities recommended in the ESC guidelines. So as I mentioned, it is important to know what occurs during a spontaneous event. That is the gold standard for diagnosis. And if the patient has got infrequent and transient symptoms, recurrent over weeks or months, are unlikely to be diagnosed by a 24-hour snapshot, So the longer the duration of monitoring, the higher the chance of picking up the events. So we can see always a ILR, implantable loop recorder, would be much better than a 24-hour Holter. This lady with a sinus bradycardia and sinus pauses, on Holter, you are lucky to get a documented sinus pause. So if the frequency is, almost daily, a 24-hour Holter would do. If it is every month, an external loop recorder, an extended period would be much better than. Despite all preliminary investigations, in 30 to 40% of the patients, the cause of syncope may still remain undiagnosed. So you need extended monitoring using loop recorders. Loop recorders will have a retrospective memory which continuously records and deletes the patient ECG. It has got two components. One is an auto activation feature. If there is a pause as predefined, let it be 3 seconds or more than 4 seconds, it records the event. And similarly, patient can activate this event if the symptoms develop. They underline that particular episode. This can be an external loop recorder or an implantable loop recorder. ELR is indicated if the patient has got recurrent pre-syncope or syncope with an inter-symptom interval of less than 4 weeks, suspicion of arrhythmic origin, and absence of high-risk criteria that require immediate hospitalization or intensive evaluation, which otherwise would be indicated for an immediate pacing or hospitalization. So patient with among sick sinus syndrome, if you have a symptomatic patient with a sinus bradycardia of less than 50 beats per minute, in the absence of negative chronotropic medication, you should not subject to ELR. These patients become directly a candidate for pacing. Let us see two cases. This is a case of transient loss of consciousness. A 6-year-old girl with a frequent episodes, multiple evaluation, nothing came out. It's so transient that nothing could be recorded during events. And on day 14 of external loop recorder, patient had clinical symptoms and the ECG was absolutely normal. So this has got a high negative predictive detection value, and the symptoms were labeled, diagnosed as functional. When you have an implantable loop recorder, the longevity is quite high, 36 months, and it records much more EGMs. Obviously, you have device-related problems. You need an implantation procedure, you need an explantation procedure. But the evaluation is done by the implanter in this case. In ELR, the implantation as of now, it's done by an external external evaluator. This is the implantable loop recorder by which is called reveal, the simple incision at second intercostal space. This is a patient activator. You can have a patient activation as well as automatic activation, and you can predefine the duration to detect it as asystole, 3 seconds mentioned here. And this is a pause detected in an implantable loop recorder. A case of transient loss of consciousness, another one. A very sick patient, 72-year-old male, diabetic for 30 years, post-CABG, history of MC infarct, multiple episodes of transient LOC. We did all evaluation, neurology, heart, invasive EP study, everything normal, but still continue to have, we put an implantable loop recorder. An ideal case because it happens only once in 3 months, 2 or 3 months. And within 1 month, it's quite surprising, you can see 38-second pause. This was during sleep, and the patient had noticed to have a seizure-like episode, and 38-second pause without any sinus node activity. You have to believe it because it's an implantable loop recorder, and it will give very clear electrogram, and there is no scope for detachment. This patient received a pacemaker. And coming to the last part, it's electrophysiological study. It has got only an adjuvant role to clinical findings. None of the indications for permanent pacing actually uses information from electrophysiological studies, and most methods used, whether it is a sino-atrial conduction time, whether it is sinus node recovery time, corrected total recovery time, whatever it be, these tests provide only indirect and impure analysis of sinus node automaticity and conduction. These are the usual values we look for, and another one is to do an atropine test, and if it is greater than 90 beats per minute and it increases over the control rate of around 20 to 50%, we assume sinus node response. Whatever we have noted, the bradycardia is due to autonomic dysfunction. In the lab studies also we have to do, like thyroid function test, all these patients, we have to exclude this patient is not on any drugs, serum electrolytes, ESR, as we have seen collagen vascular disease can even present with sinus node abnormalities because of, and some infiltrative disease like sarcoidosis, amyloidosis, hypercalcemia, hyperkalemia, and other directed investigations as per clinical suspicion. And also important to note that to pace these patients as per class 1 recommendation, you need symptoms. We need only symptomatic patients would require pacing in case of sinus node dysfunction. So ladies and gentlemen, my conclusion is that sinus node dysfunction can have varied presentations, and it is important to recognize them for proper management of these patients. The correlation between sinus poses and symptoms, it is the cornerstone for diagnosis. An EP study has got a limited role in the evaluation of sinus node function, and always rule out reversible etiological factors before you pace a patient. Thank you.
Thank you very much, Dr. Namudri. I am sure your talk stimulated all of us to have a relook into the sinus node. Now the topic is open for discussion.
There is a test which they do the total abolition of parasympathetic influence on the SA node by giving atropine.
Yes, sir.
And then total abolition of sympathetic this thing by giving beta blocker.
Yes, sir.
I would like to know, when do you do this test, and do you do it in your usual practice because you are a EP man?
Yes, sir.
And does it really help, and what are the indications for this? Is it a good
Sir,
test?
as of now, it is not recommended. It's not routinely done. It's called intrinsic heart rate assessment. What we do, we take off both sympathetic as well as parasympathetic influence on the sinus node, so that you know whether sinus node is intrinsically normal or abnormal. The process is to give 0.2 milligram per kilogram propranolol over a 10 minutes period and wait for 10 minutes, assess the sinus nodal active rate, then give 0.04 milligram per kilogram atropine and to see the sinus activity. The standard one is 118 minus 0.57 into age. If it is more than that, it usually comes around 107 or so. If it is more than that, sinus nodal activity is absolutely normal, and whatever bradycardia you have noted is due to excessive vagotonia. Many times, if you give atropine and take off the vagotonic effect, and if the heart rate goes beyond 90 to 100, you know it is clearly related to the vagotonia. So you don't have to give propranolol in addition to atropine. And people had problems by giving IV propranolol and atropine, and it has to be done in an electrophysiology setting. And exercise testing is as good as, or atropine is as good as, intrinsic heart rate assessment. Thank you.
On the surface ECG, how do you differentiate between sinus pause and sinus exit block?
Sinus pause
and sinus exit block on the surface ECG.
Yeah, I already shown that slide, but because of brevity of time, I just if you show it is multiples of PP interval at basal, you can clearly diagnose a second degree type 2 SA block. And type 1 you can diagnose by fusion, that is grouping of PP intervals. I'll just show that, because you cannot see the onset of the intrinsic the electrograms at the sinus node. You infer this by indirect grouping of the P waves. Here, this is the second degree type 1 sinoatrial block. You can have, when you have a typical Wengi-Back with AV block, though often we see the AV prolongation, you should also note that RR interval shorter. here you cannot see the equivalence of the P wave, that is the sinus nodal activity. So you infer based on the shortening of the PP intervals and losing one particular P wave in type 1, and in the type 2 the PP intervals remain same, and whatever the PP interval you have is multiples of baseline PP interval. This is the way it is shown. You have, and if it is not multiples, it is a sinus pause. A sinus pause could also be due to, but it's basically a sinus arrest. The importance is that sinus arrest you denote automaticity losing the automaticity, and in sinus exit block the abnormalities with the conduction. Thank you.
How much importance do you give to the mortality risk of out of 6 sinus syndrome? What is the actual mortality risk out of 6 sinus?
The studies done prior to, in the 80s had assessed this, and no study had shown significant improvement in mortality with the paced and controls. That is why the level of evidence is C even now.
Another question is, how do you assess chronotropic incompetence during stress testing?
Stress testing, if the expected heart rate 220 minus age in 80% less for females, if you achieve 70 to 80% of the heart rate, you diagnose there is chronotropically competent. If it is less than 80%, you can.
How long exercise you do? We do by 85% target heart rate to achieve the during exercise for assessment of the ischemia. But how do you assess it? What percentage of patient his exercise may limit?
The patient cannot exercise as such. You can give atropine and assess. For atropine, it is around more than 100 beats per minute. It is considered as chronotropically competent. Then,
if there are no questions, we will close the session. Thank you very much, Speaker.
thank you.
Thank you, sir. I now request Dr. Ketan Mehta to hand over a certificate to Dr. Narayan Nambudri. And I request Dr. Narayan to hand over the certificates to the chairpersons.
The next session will be chaired by Dr. Amit Vora, electrophysiologist and previously Associate Professor at the Department of Cardiology at KEM Hospital, Mumbai, Dr. M.V. Krishna, Professor of Medicine at Rajarajeshwari Medical College, Bangalore, and Dr. Usha Lakshmi, Professor of Medicine at Kilpauk Medical College, Chennai. Kindly proceed to your designated seats. I invite our speaker for this session, Dr. S.P. Gupta, onto the dais to speak on ECG changes due to drugs and electrolyte disturbances. I request the chairpersons to introduce Dr. S.B. Gupta.
Dr. Gupta is President of Indian Society Electrocardiology and is in fact the pillar of the society and needs no introduction. So we will go on to Dr. Gupta's deliberation on drugs and electrolytes, how it affects the ECG.
Good afternoon and thank you very much, chairpersons. This topic is of a lot of clinical relevance, and I do not know whether I can cover all the drugs which can cause arrhythmias, and there are lots of arrhythmias which can be caused by the drugs. But I think just to be brief, I think there are a lot of conduction disorders which are being due to drugs, which may be because of the beta blockers or because of the calcium channel blockers like verapamil or diltiazem, digoxin. There are a lot of other antiarrhythmic drugs which can also cause conduction disorders. Then opiates, organophosphates, pesticides, clonidine, and ethanol in a larger quantity can also give rise to conduction disorders. And these conduction disorders can be, I think the basic one is it could be just a sinus bradycardia, and like this patient of hypertension who is also on beta blocker can have a sinus bradycardia. So this is one of the commonest arrhythmia which can happen. And the other arrhythmia, I think it has been discussed by the previous speaker also, that the sinus node dysfunction in the form of either SA block or could be a sinus pause can again be because of these drugs. Any type of AV conduction disorders, maybe it's a first degree AV block, maybe it's a 2:1 or second degree AV block, or maybe the advanced high grade AV blocks, or even a complete AV block, can also be because of all the drugs which I have mentioned in my first slide that can lead to these conduction disorders. Then there are certain drugs which can cause sinus tachycardia. It could be and drugs like parasympatholytics, like we have talked about atropine or preventine. Sympathomimetic drugs, whether it's used for like adrenaline, or even the drugs which are used for the relief of bronchial asthma, like salbutamol or any other advanced drugs, can lead to sinus tachycardia. A lot of antihistaminics are there, amphetamine, theophylline group of drugs, or cocaine can cause a sinus tachycardia. Like any sinus tachycardia like this can be caused by the drugs which I have mentioned in the previous slide. I think the most important aspect of the safety of the drugs nowadays, I think practically most of the drugs which are being marketed now have to go under this cardiac safety, whether this drug has got any effect on the QT interval, because the prolongation of the QT interval is a hallmark for a serious fatal or lethal arrhythmia, which is torsade, and which presentation symptom can be a syncope and can lead to a sudden cardiac death. So we have to, I think, very, very careful as far as the prolongation of QT interval is concerned with the drugs. And there is a whole list of the drugs which can cause the prolongation of QT interval. And these are the anti-arrhythmic drugs. There are drugs which have been marked red, which shows these drugs are the top 20 drugs which can cause the prolongation of the QT interval. And the drugs which are starred, have got an asterisk mark, have been associated with torsade very commonly. So the drugs which are there, the anti-arrhythmic drugs like quinidine, procanamide, disopyramide, asmeline, ancanide or flecainide. Then drugs like the very commonly used drugs, people use amiodarone left and right, but these drugs can cause a prolongation of QT interval, can lead to torsade. So amiodarone, sotalol, beryllium, abutylate, dubutylate, and other drugs, and the commonly used drugs, the digoxin. Then again, there are a lot of other drugs like calcium channel blockers. There are two asterisk marks are there, which the drugs which have been withdrawn from the market because of their prolongation of the QT interval and the torsade. So the prenylmine, bepredil, and pterodilene have been already withdrawn from the market. There are, I think, I do not know how many psychiatrists, when they are using the drugs, they know that these drugs can cause prolongation of the QT interval and can even kill the patient because of the torsade. There are a lot of, again, drugs, the psychiatric drugs. I think this is the longest list of the drugs which can cause the prolongation of the QT interval. Haloperidol, which is very commonly used by the psychiatrists. The tricyclic antidepressants are very commonly used by the psychiatrists. The SSRIs, which are very commonly used by the psychiatrists, can cause a prolongation of the QT interval. They do not know, and they may feel the symptoms are not because of the drugs, but they can, I think these drugs can kill the patient because of the prolongation of the QT interval and the torsade. So there are a lot of drugs which are very commonly used drugs like fluoxetine, very commonly used, doxepin, very commonly used, lithium is very commonly used, the tricyclic antidepressants like amitriptyline, nortriptyline, they are very commonly used drugs, but they can cause prolongation of the QT interval and torsade. Then we are using a lot of antihistaminics. Again, just a common cold, we prescribe a drug, again can cause the prolongation of the QT interval. There are a lot of antibiotics, which are again can cause the prolongation of the QT interval. Commonly used drugs, even the pediatrician use the erythromycin, the clarithromycin, the ketoconazole, the fluconazole, and quinine, chloroquine, antimalarials, halophantrin, and again the quinolones. Any quinolones can give rise to a prolongation of the QT interval and can lead to torsade. So I think when we are using any drug, one should keep that thing in the mind, whether this drug can cause QT prolongation, and then if it can cause QT prolongation, then one has to monitor the ECG. Then I have told you about the serotonin antagonist, agonist, they can cause QT prolongation. Immunosuppressants like tacrolimus, which is being very commonly used by the nephrologist, can cause the QT prolongation. Antidiuretic hormone, vasopressin, and even the very commonly used drug Lasix, furosemide, can cause QT prolongation. The other agents like organophosphates and piperine, cocaine can also cause QT prolongation. And this is one ECG of quinine-induced QT prolongation in a 45-year-old malaria patient. So just for an example. And this is again an example of very wide QT prolongation in a patient who is being treated by antipsychotic drugs. This is one example of the quinolones which can cause the QT prolongation, and I think on the right hand side the moxifloxacin and sparfloxacin is one of the important quinolones which can cause a marked degree of QT prolongation. This is one patient who has been survived of the cardiac arrest after the QT prolongation and the torsade, and soon after the survival, after the cardiac arrest resuscitation, you can see on the upper strip is the QT prolongation, and after 3 days the QT has become normalized. And this is one example that the QT prolongation can lead to a polymorphic VT or torsade. This is one example in which can culminate into a ventricular fibrillation and can lead to a sudden cardiac death. And normally there can be a long and short cycles before it culminates into a polymorphic VT or torsade. I think there are again many drugs which I think most of these drugs can lead to ventricular arrhythmias, and the common drugs which can lead to ventricular arrhythmias otherwise also the digoxin, the tricyclic antidepressants, aminophylline or deriphyllin group of drugs, pseudoephedrine, fluoxetine, cocaine, amphetamine, caffeine, alcohol and anesthetics can lead to ventricular arrhythmias, and these ventricular arrhythmias may be single PVCs or could be bigeminy or trigeminy or couplets, triplets, or non-sustained monomorphic VTs can happen because of any of these drugs, or it can lead to even a sustained monomorphic VTs. I think one of the drugs which is again not going out of the way vogue is digoxin, can give rise to a lot of arrhythmias, and I think because of that reason and because of the increased morbidity and mortality, the drug is not commonly used nowadays. It can lead to decreased AV conduction. It can lead to, I think, the sign mark ECG is of digoxin is atrial tachycardia with the 2:1 conduction or 2:1 block. Then it can lead to frequent PVCs.